So I already introduced myself. Welcome to Stop the Review. Okay, so the first question is a 29-year-old female, multiple complaints, abdominal pain, nausea, vomiting, diarrhea, palpitations, and subjective features. Heart rate is 145, blood pressure is 150 over 90, respiratory rate is 15, 7.9% of air, and head temperature is 100.8. She's agitated, moderately ill appearing, she has diffuse thyromegaly, irregularly irritable heart rate, her lungs are clear to auscultation by lateral. Her pregnancy test is negative and you suspected thyroid. What is the best next step management? So you have A, wait for thyroid studies to confirm diagnosis prior to initiating treatment. That's pretty well. B, PPU, beta blockers, hydrocortisone, iodine simultaneously. C, methimazole, beta blockers, hydrocortisone, and iodine simultaneously. Or C, methimazole, beta blockers, hydrocortisone simultaneously. Awesome. Also, you guys got it right. So thyroid storm is a clinical picture, and if the patient's story and clinical exam is highly suggestive for it, you don't wait for your thyroid studies to come back. You treat the patient. So we can quickly go through these answers. So back answer about A. The reason why B and C are wrong is so iodine is a substrate that's needed for the conversion of you shouldn't give it right away because it works into thyroid score. So to give iodine, you have to give lights to suppress thyroid hormone synthesis first, and then you give iodine. In this case, you can between PTU and methimazole, PTU is preferred in the ICU setting when your patient is crashing, looking like they're about to die. It is faster acting and it reduces like T4 by 45% in the first 24 hours. Whereas when the patient is severely ill but not dying right in front of you, you can use methimazole. Of course, PTU is preferred in first trimester pregnancy, but it is safe in second and third trimester. And PTU has a black box warning for causing severe liver dysfunction. So your patient's alcoholics with cirrhosis, this is not a medication yet. Okay. So any questions about that? Great. On to the next one. Right. So my next question is a 20-year-old female, no significant past medical history, came in after synthesizing while spending infusion. She has fatigue, weight loss, dizziness for the past 9 months. Tachycardic, hypotensive, sample 37, starting well. Her exam shows hyperpigmentation and dryness of memories. And the question is, which of the following abnormalities is expected? Is it A, hypernatremia, hyperkalemia, hypoglycemia, B, hyponatremia, hypokalemia, C, hyponatremia, hypokalemia, and hypokalemia, or D, hyponatremia, hypokalemia, and hyperkalemia. Seems like most people have answered, so awesome. Most of you guys got it right. So this is Addison's disease with the story, the hyperpigmentation, the hypotension. With Addison's disease, it's primary adrenal deficiency, so you get a deficiency in cortisol, aldosterone, and gonadotropin. The deficiency in cortisol and aldosterone causes a secretion or a resorption in sodium and secretion of potassium in the renal tubule. So deficiency of it causes a type 4 RPA, where you get hyperkalemia, metabolic acidosis, And because in response, you get a lot of ADH secretion, you're retaining a lot of water, which worsens your hypertension. Okay, that's the next one. Which one of these is not required for the diagnosis of alcoholic ketoacidosis? Is it A, elevated anion gas, B, metabolic acidosis, C, elevated serum glucose, or D, ketonemia? Awesome. You should have talked about this in the breakout session. But in alcoholic ketoacidosis, your serum glucose will either be low, normal, or it causes an elevated anion gas, you get metabolic acidosis, and you get ketonemia. Okay, the next one is true or false. Alcoholic ketoacidosis is precipitated by the depletion of NADH. Wow, that was really close. So the answer is actually false. This was kind of a trick question. It's actually depletion of NAD. So when you're metabolizing alcohol, you're using all of your NAD to metabolize into NADH. So your NAD is turned into NADH. So you get depleted of NAD. NAD is needed for the Krebs cycle aerobic respiration. If you don't have it, it induces glycogenesis, gluconeogenesis, glycolysis, and glycolysis. So you form a lot of ketone bodies. So you get an excess of NADH and a depletion in NAD. What is the most common cause of hyperthyroidism? Is it Graves' disease, thyroiditis, medication-induced, or thyroiditis? Yeah. So Graves' disease actually causes 60 to 80% hyperthyroidism, so it's the most common. Good job, Major Laser. Which one of these is not included in the virtual top speed scale used to determine the likelihood of thyrotoxicosis? Is it A, VNS effect, B, temperature, GI dysfunction, or oxygen saturation? This should be easy. Awesome, almost everybody got it right. I'm not going to go into details for sake of time, but oxygen saturation is not one of the criteria. And which one of these medications should be avoided in a patient with thyroid storm and acute decompensated CHF? Is it A, methimazole, B, PTU, C, beta blocker, or D, constarine? Almost everybody got it right. So yes, beta blockers are contraindicated in decompensated CHF. They have a negative inotropic effect. So if the patient is food overloaded, decompensated, this is not a medication you want to use. We talked about this. Calcium channel blockers in this case be a little bit more helpful. Still have a negative inotropic effect, but not as bad as the beta blocker.
Right, and in the old days, we would use digoxin. I know people are not used to using it anymore, but you can use it IV, but it's old. But that's what we would do in the old days, right, Mike? Yeah. In the ancient days.
So that could be saying that in the olden days, they used to use digoxin in the patient to decompensate CHF. I've seen it used actually.
Yes,
in my patient with thyroid storm, So it is still used to this day.
I had to say it that way to thank the chairman.
I will warn everybody that Dr. Gernsheimer was my attending. I was the president.
All right, so my next question, I have a 16-year-old female with no medical problems, presents with hypotension, blood pressure is equal 40, and she's diagnosed with adrenal crisis. You administer 1.5 liters of IV fluid and a bolus dose of high cortisol. With some improvement in her blood pressure, but the hypertension persists. What is your next best step? Right. Is it A, you start vasopressors due to decreased circulating catecholamines? B, you administer more fluids? Is it A and B, or is it B, a second dose of steroids? Right, this is kind of split. Most people choose A. A isn't necessarily wrong, but you wouldn't jump to vasopressors. This patient only got a liter and a half of fluid. These patients tend to be very, very volume depleted, requiring several liters of fluids. So you give more fluids, and then if they're unresponsive, then you jump to the steroids. True or false? Thyroxine is preferred in elderly patients and patients with cardiac disease in the treatment of mixed edema. Wow, okay. The answer is actually true. So thyroxine is T4 and triiodothyronine is T3. T3 is much, much more potent and it can induce cardiac arrhythmias and infarction. So essentially in elderly patients and anyone with an underlying cardiac disease, you want to use T4 instead. You run into less risk of causing arrhythmia. So the answer is true. Well, I have a 45-year-old male, alcohol abuse, presented with abdominal pain or vomiting and ultimate status. He's found to have alcoholic ketoacidosis. Initial pH state is within normal limits. He ordered IV fluids with dextrose, uriculated electrolytes, but somehow the patient's mental status later changes. He develops confusion, ophthalmoparesis with nystagmus, he has ataxia. So the question is, what precipitated this patient's change in mental status? So this was a little bit tricky. This is actually, this patient developed rare encephalopathy, the triad ataxia, confusion, we can have some complications, and ophthalmoplegia. So at first, so rare encephalopathy is fine. So in this patient, we started the right treatment, you give dextrose, you depleted the electrolyte, but this patient was probably already deficient in thiamine. So giving the dextrose, thiamine is necessary in the metabolism of glucose. You give glucose, you basically deplete all the thiamine that they have left, which can send this patient to having very encephalopathy. So the precipitation is the dextrose, and thiamine, deficiency in thiamine is what causes the
But it's like important to note that, they always stress like give thiamine then dextrose. That doesn't really probably matter so much, but you should just be giving them like at the same time.
Exactly. Yeah, it doesn't have to be from whatever, you don't have to give time, you can give it at the same. But if you start treating, with the dextrose, treating your thiamine, you can, potentially, send them to the Now, if your patient is altered because they are hypoglycemic, then that's a different story, right? Then you give your dextrose, get the thiamine for now, and you can give it later, but fix the hypoglycemia.
In my experience, like the thiamine takes a little bit to be prepared.
Yes.
And so they don't get it right away, but you can get them the dextrose containing fluids like right away.
Definitely.
Yes, good. Yeah, the brain needs glucose when it's low. It really is very dependent on glucose. And I just want to tell another Gershon story from yesterday, from UHB.
Dr. Gonzaga is about to tell us a story.
And about a great resident. So I come in from teaching upstairs, and Shar comes to me and says, "We have this guy who's acting crazy. He has a history of schizophrenia, but he's very sweaty, and he goes from being laying down and hardly breathing to going and trying to drink stuff out of his dirty sink." Right? He's really, so we go over to see him, and now he's laying down. He's not that agitated, but he's mostly, we're going to give him Versed to get stuff done. But he's kind of out of it. So Shar says, "Oh, let's check a dextrose stick." Right? It's basic, and she hit right on it. 28. Right? Gave him 2 amps of B50. Starts to get a little better, getting more with it. Half hour later, recheck a dextrose stick, it's down to 38. Give another B50. Probably turned out that he'd gotten his hands on somebody's oral hypoglycemic agent. Kept coming down. But finally, he came around. We started giving a drip of D5, and I was going to give him D10, and gave more D50. And we were about to give him oxyatrid. I was going to do it because I was so convinced he took something, but he came around, and we admitted him to it. But Sharp right away said, "Yeah, let's check a finger stick." 28. So basic. The brain needs sugar, and if it's low, you give it. And then you give the thiamine if they're cachectic or an alcoholic. But you're right. A lot of times it takes time for the nurses to give it. Plus, if you read the nursing textbooks, they all say give the thiamine as a drip because they're afraid of an anaphylactic reaction, which is rare. I've only seen it once. So, but they won't give it fast. But the glucose, you can give it, and you can give the thiamine. So, yeah, don't hesitate. They're hypoglycemic and altered mental status, give them the sugar. Sweets for the sweet, honey for the honey. Okay.
Awesome. Shout out to
Nice
Shar.
song.
Shout out to Shar. Yeah, you made it to a good job story. I call out success. Alrighty, do you guys have any questions about any of these? If not, that will be the end of my presentation.
Very good.
Excellent.
Now you're going to send out the answer to the topic review, right?
Yes, yes.